Good afternoon, everybody. Welcome. This is the Health and Social Services Subcommittee on Appropriations budget hearing today on the Medicaid program. I am Delegate Emily Shetty, chair of the committee. Our vice chair is out sick today. Everybody send her your best wishes, but joined by our most amazing committee members and our awesome committee counsel, Joe. Thank you for the DLS analysis. We're going to turn to our budget analyst, Ann Braun, to kick us off. Thank you.
Thank you, Madam Chair, members of the committee. As you presented, today I am here to present the budget analysis for the Medical Care Programs Administration. That includes Medicaid and the Maryland Children's Health Program. The fiscal 27 allowance is about $14 billion, and that reflects an overall decrease of $215 million compared to the fiscal 26 budget. However, the fiscal 26 budget includes a deficiency to cover a shortfall of $295 million for prior year expenses. And so when you include those funds and compare just the fiscal 26 expenses to fiscal 27, the budget actually increases by $80 million. I'm going to jump to page 9 to discuss the performance analysis. MDH conducts multiple activities to collect quality assurance data and monitor MCO performance within the managed care program. This analysis focuses on HEDIS measures, and those are used by 90% of health plans nationally and allow for comparison across for participants' health outcomes and access to care across the healthcare system. Exhibit 3 shows the share of HEDIS measures at or above the national mean for each MCO and the average across Maryland's 9 MCOs. Overall, most of the MCOs perform better than other plans, with more than half of their reported measures being at or above the national mean. The statewide average was 57% in calendar 23 and jumped to 67% in 2024. This continues the improvements that have been seen since the COVID pandemic, when these results worsened as participants delayed care and providers had less capacity. The improvement from last year is seen across the board as all MCOs show improvement, but the extent of that improvement varies widely, from less than 1% increase to an increase of 25 percentage points. Through annual agreements with each MCO, MDH requires certain levels of performance and can apply sanctions based on the results on HEDIS measures. Beginning with calendar 2025, MDH can now exclude MCOs from the Population Health Incentive Program if they don't reach certain HEDIS results. Another requirement that MDH enforces is that MCOs must be accredited by the National Committee for Quality Assurance. In February 2025, Priority Partners accreditation was suspended, and MDH froze new enrollment until just earlier this month after Priority Partners restored its accreditation. The second performance discussion covers the MCO Population Health Incentive Program. This is the pay-for-performance program in which MCOs can earn up to a certain percentage of their capitated rate payments for achieving performance benchmarks or demonstrating improvement on measures that MDH selects. In both fiscal 26 and 27, the budget allows for up to 0.25% of capitated rates for these incentives. As of the writing of this analysis, the annual report on the incentives wasn't available, but MDH has since published this report. We still ask MDH to discuss why the report hadn't been published until just recently and to provide the 2024 results by MCO. The last performance discussion covers Medicaid and MCHIP application processing. For those qualifying based on income, called MAGI groups, the Health Benefit Exchange processes those applications and renewals. For the non-MAGI groups that qualify based on disability status or spend down from nursing home or long-term care expenses, DHS processes those cases. Exhibit 4 on page 13 shows the average processing time in days and the number of applications received for the different eligibility groups. MAGI cases tend to be processed much quicker. You can see that for most of those groups, processing took less than 24 hours. And that's also because a lot of those renewals can be auto-renewed. The non-MAGI cases generally take longer to process, even though there are fewer applications. And that's because the eligibility requirements are more complex. All non-MAGI categories were processed below the federally required 90 days. But that's on average. Past reporting has shown that there are consistently a share of applications that do take longer than the 90-day requirement. And so MDH is asked to discuss the primary reasons for delays in processing non-MAGI cases. And so turning to page 14, this begins the budget discussion. First, I'll talk about some fiscal 25 items. At the end of each fiscal year, MDH typically accrues funding to cover services provided in that year, but the bills come in the following year because providers have a year to submit their claims. At the end of fiscal 25, the amount accrued for fiscal 26 payments does not appear to be sufficient based on the projected claims so far. As I mentioned earlier, the budget includes a deficiency of $295 million to cover the shortfall for prior year expenses. However, after looking at the claims data through January, the estimated accrual shortfall has decreased. And so DLS is recommending a reduction of $70 million from the deficiency, and that includes $10 million in general funds. We note that that would still leave $12 million in general funds beyond what is expected to be needed for the carryover spending. The next discussion is on outstanding liabilities reported at fiscal 25 closeout. This relates to a nursing home disallowance and MCO payments for deliveries of babies with very low birth weight. MDH accrued a total of $160 million for these costs, but then reported that it thought it would need $27 million in general funds on top of that. And so that appeared at fiscal 25 closeout as a shortfall and unprovided for payable. Using the reserved funds, MDH has paid $27 million to cover the outstanding MCO payments. And on the nursing home disallowance, this was resulting from a rate increase that was not approved retroactively by CMS. The department is currently negotiating a budget-neutral way to pay back the federal reimbursements. MDH is asked to provide an update on these negotiations and how the disallowance could be resolved without additional payment from the state. MDH should also clarify how much in outstanding MCO payments are still owed. Depending on the amount that's still owed to MCOs, up to $66 million in general funds from that accrued amount might not be needed in Medicaid. And so we point out that that additional funding could be transferred to other MDH programs with shortfalls. Moving on to fiscal 26, there are 5 deficiencies described on the bottom of page 15. That adds $161 million in general funds to the budget. Of this funding, $106 million covers higher than expected Medicaid enrollment, healthcare utilization, and inflation, although this is partially offset by $12 million reduced from the Maryland Children's Health Program, also based on spending and enrollment trends. The next discussion is on the requirements for MCOs to meet certain medical loss ratios. These ratios measure the amount of payments that support mandated medical services and quality improvement. Exhibit 5 on page 17 shows the results by MCO for calendar 2023. The MLR ratio must be at least 85% for each MCO, and if not, a remittance is paid back for any MCOs that fall below that requirement as a guardrail for MCO profit. Aetna, Kaiser, and WellPoint did not meet the MLR requirement in calendar 2023 and paid MDH a total of $151 million in fall of 2025. Of that, $44 million is the state share. This recovery has not yet been accounted for in the budget, and so DLS recommends reducing the deficiency by the total amount of savings from the MLR recovery, including that $44 million in general funds. Moving to the discussion of the allowance, on page 20 and 21, this shows the proposed budget change from 26 to the 27 allowance. The overall decrease is $215 million, but as I said earlier, after pulling out the fiscal 25 expenses, the change between 26 and 27 is actually an increase of about $80 million. The largest driver of that spending growth in Medicaid is a net increase of $428 million for MCO and hospital rate increases. I'll also highlight that there's $21 million in higher anticipated spending and enrollment under the Community First Choice program, and that supports home and community-based services. Additionally, I'll highlight that there is just under $10 million added to expand biomarker testing. That would expand the testing from just cancer to other conditions like heart disease, infectious disease, and genetic testing. These increases are partially offset by reduced enrollment assumptions, and that accounts for a $306 million decrease. Also highlights certain programs see decreases, like Money Follows the Person. That program assists individuals transition from nursing home or institutional care to home and community-based settings. And that program sees a decrease partially due to federal changes that reduce the cap on administrative costs. Pages 22 and 23 begin the section on special fund sources. The first discussion is on the Cigarette Restitution Fund. This was covered a lot more during the MDH overview presentation. I'm flagging this here, though, because you'll see technical recommendations to add and specify the contingent language related to the BRFA provisions related to the Cigarette Restitution Fund. The next item discusses provider assessments on hospitals and nursing facilities. This continues to be the largest special fund source for Medicaid. In fiscal 27, it's expected to cover about $791 million, and that's before counting the federal match that these funds generate. The One Big Beautiful Bill Act gradually reduces the cap for hospital and MCO provider assessments from 6% of net patient revenue to 3.5%. The nursing facility quality assessment is exempt from the lower cap. Even though current provider taxes affected by this provision are already near that 3.5% cap, there are still some concerns with implementation that we point out. First, Maryland's hospital assessments are collected through HSCRC's rate-setting authority rather than CMS approval, and that leads to uncertainty for how the OBA provisions will be applied. And then second, there are currently some hospitals and nursing facilities that are exempt from the assessments, and so it's possible that they will need to start being included for the state to meet CMS's uniform and broad-based tax requirements. And MDH is asked to provide an update on whether it's received any federal notices or plans to make any changes to the provider assessments. Turning to the exhibit on page 25, this starts a discussion on the Senior Prescription Drug Assistance Program. Under that program, MDH provides premium assistance for Medicare Part D plans to certain income-eligible Marylanders. Exhibit 9 shows that enrollment has gradually decreased in this program, and Exhibit 10 shows expected revenues and expenditures for this program's special fund. BRFA provisions in recent years expanded the authorized use of this fund to include behavioral health and support for state retirees who are transitioning to Medicare Part D. And you'll see that the budget includes a $5 million transfer to BHA in both fiscal 26 and 27, but there isn't a transfer to DBM for the state retirees in fiscal 27, although that is an ongoing authorized use of this fund. And so considering that there's an estimated $9 million balance, DLS recommends authorizing a fund balance transfer to DBM and reducing $3 million in general fund savings. And that recommendation will appear in the DBM personnel analysis. Pages 27 and 28 discuss a BRFA provision that would transfer $6.7 million from the Maternal and Child Health Population Health Improvement Fund to the general fund. The BRFA of 2021 created this fund to receive support through HSCRC hospital assessments to pay for maternal and child health initiatives in Medicaid and in MDH's public health program. HSCRC approved an assessment of $40 million that was initially set to terminate after, or the fund was set to terminate after calendar 25, but that was extended through the end of calendar 27 through legislation passed last year. Between the $13.1 million transfer approved in last year's BRFA and then the proposed transfer this year, that would be $19.8 million, or almost half of the approved assessment that would be proposed to be transferred to the general fund. Exhibit 11 shows the budgeted expenditures, which would be more than the available funding after the transfers. And so MDH is asked to provide fiscal 26 year-to-date spending and to explain why Medicaid and public health programs have underspent this funding. MDH should also work with DBM to adjust the budget to accurately reflect the planned spending in fiscal 26 and 27. The next item on page 28 relates to a new major IT project for Medicaid pharmacy services. The current contract for the claims management system will expire in July 2029, and this project will replace that system. The budget includes $1.5 million all in general funds within DO-IT's budget, but MDH reported that the project is expected to receive the typical 90% enhanced match for IT development. And so DLS is recommending reducing $1.35 million of the general funds in anticipation of the federal match. And this recommendation will appear in the do-it analysis. Page 30 begins the discussion on provider rate changes. As I mentioned, the budget includes a net increase of $428 million across MCO and hospital rate increases. Exhibit 13 shows the recent MCO rate changes and the estimated cost impact on the allowance each year. You can see, should note first, MCO rates must be actuarially sound, and each year Maryland generally sets the rates at the bottom of the range to be actuarially sound. And so seeing growing rate increases are reflective of actual higher cost and utilization of healthcare services in managed care. According to an analysis conducted by Hilltop and Optimus, the state's actuary for MCO rate setting, some of the key drivers of the higher cost are maternal health, specifically the payments for deliveries. And this is due to both increases in the cost of the deliveries, but also utilization, because there have been more reported hospital admissions and services for higher acuity cases being reported. Pharmacy costs have also been a driver of this spending growth, especially for certain prescription drugs for HIV and also GLP-1s that's covered for certain conditions and comorbidities. It also reflects significant increases in cost and utilization in the past 2 years. For hospital services, the higher cost is mainly driven by utilization among the disabled and elderly populations. From 2023 to 25, there's been a sharp increase in utilization, and that's partly due to the pent-up demand and the higher acuity that built up during the pandemic, while participants held off on receiving care or had less access to care. And so you've seen, unexpected large growth in healthcare utilization, and so you're seeing it now in MCO rate increases and hospital update factors. The budget does not include a rate increase for long-term services and supports providers in nursing homes, and physician evaluation and management rates are budgeted at our level, but right now they're almost 99% of Medicare rates. However, there are some new opportunities for primary care providers to receive enhanced rates and other incentives through the new Advanced Primary Care Program. It's also called the Medicaid Path, and that is part of the States Ahead model. Moving to the enrollment forecast, page 36 shows enrollment by eligibility group that's assumed in the budget and versus projected in the DLS forecast. Overall, the two forecasts are generally in alignment. In fiscal 26, enrollment has decreased more than projected, and so the budget reflects further decreases compared to what was assumed when the budget passed last year for most groups. The OBA impacts on eligibility and disenrollments are considered for both forecasts due to the delayed effective dates for some of the larger provisions like work requirements. The effect on enrollment isn't expected until later in fiscal 27, and so that makes the overall enrollment decrease just under 1% in both forecasts. The only notable difference among the eligibility groups is that DLS projects a larger decrease in the number of non-citizen pregnant women who are covered through the Healthy Babies program. This program is not affected by any provisions in the One Big Beautiful Bill Act, but DLS is projecting a more pronounced chilling effect and a larger impact from reduced immigration trends. This affects the cost forecast by reducing prenatal and postpartum care, but the DLS forecast still assumes the delivery costs would be needed and it would be covered through emergency medical services for undocumented immigrants. Pages 37 and 38 discuss the general fund adequacy of the budget. Considering the enrollment forecasts are very similar overall, the budget and the DLS forecast do not have significant cost differences from enrollment. I noted earlier that fiscal 26 does not yet account for the $44 million in general fund savings from the MLR recovery, and then combined with the identified $10 million from the accrual trends, that provides $54 million in general fund relief from fiscal 26. After accounting for that, the fiscal 26 budget appears more than adequate to cover projected costs. In fiscal 27, there are some differences between the forecast due to utilization assumptions, but as I described earlier with MCO and hospital rates, healthcare utilization and costs has grown substantially in recent years, and in some cases in an unexpected way. And then considering the uncertainty with OBA implementation, DLS is not recommending reductions in fiscal 26 or 27 due to forecast differences. However, I will note that to the extent there are excess general funds in Medicaid from those utilization assumptions, the excess funds could be realigned to other health programs where there are identified shortfalls. Exhibit 17 shows Medicaid and MCHIP general fund spending over the last few years and into the allowance. This is included mainly to show that rapid growth in spending through fiscal 25, and that had to do with all the utilization growth. Some of this was expected as the enhanced federal match that was provided during the COVID-19 public health emergency ended, but some of this general fund growth was unexpected. And that led to some significant deficiencies that you've seen in the past few years for MDH programs. I also wanted to point out that while Medicaid and MCHIP general fund spending is leveling off, it still takes up 17% of statewide general fund revenues. And so it's worth examining if this level of spending is sustainable. I will now move on to the issues section that begins on page 40. The first item has to do with OBA implementation. Exhibit 18 outlines the major provisions affecting Medicaid, the effective dates, and the projected impacts. Committee members, you've heard a lot of this through early session briefings, so I'm actually going to skim that part and just jump to page 42 that discusses the implementation and the updates in the budget related to OBA. The only provision under Medicaid that took immediate effect was a prohibition on federal reimbursement for all healthcare services provided by Planned Parenthood. MDH has stopped paying claims for Planned Parenthood through Medicaid, and the department is asked to describe outreach methods it is using to inform participants that those services are not covered through July 4th, 2026. In terms of budget impact of OBA, because the Health Benefit Exchange conducts eligibility redeterminations for the ACA expansion group, which is the group affected by work requirements and the more frequent eligibility checks, that budget reflects the increased cost for IT system updates and call center operations rather than the Medicaid budget. However, MDH's budget reflects a net increase of 20 positions and additional reclassifications of existing vacancies, and that's to staff up the Office of Eligibility Services to handle some of these major OBA changes. There is some funding across MDH and the Health Benefit Exchange for marketing, and MDH is planning on an outreach campaign similar to what they did during the COVID unwinding process. However, the department notes that those there will need to be some nuance to that outreach campaign because the OBA provisions in some cases only affect the ACA expansion group, or so it's a little more nuanced. I also wanted to note that Hilltop created a public dashboard to track enrollment trends among the ACA adults. Page 43 discusses some considerations as MDH is implementing the work requirements and other OBA provisions. CMS is not expected to release formal guidance until June of 2026, but MDH is planning on how to apply optional exemptions for work requirements with broad definitions where possible to limit the effects of the disenrollments. MDH is also exploring ways to use data sharing and to coordinate with other agencies to automatically exempt individuals or verify whether they already meet work requirements or income requirements. And so this could include checking against SNAP enrollment and working with DHS. DHS already administers work requirements for some of its public benefits programs. And there's also already express lane eligibility for SNAP enrollees to be determined eligible for Medicaid. MDH also described looking into wage and workforce data from the Department of Labor. They also described using CRISP health records to check for medical exemptions and receiving data from MSDE for participation in education programs that could also count towards the work requirement or the community engagement requirement. And finally, looking at tax return information from the comptroller. And so MDH is asked to comment on the timing and feasibility of these data sharing efforts. And overall, DLS is recommending that the committees request 2 reports on MDH's implementation of the OBRA provisions that affect Medicaid. The final issue appears on pages 44 through 46. This discusses MDH's response to committee narrative on how Medicare and Medicaid cover dually eligible patients with end-stage renal disease. Both programs cover comprehensive services for these patients, but individuals enrolled in both before dually eligible participants, Medicare would serve as the primary payer. Hilltop analyzed claims and encounter data related to end-stage renal disease and found that over 1,000 Medicaid participants likely qualify for Medicare due to their ESRD diagnosis. And so from that, the department estimated annual state savings of almost $10 million if more of those individuals enrolled in Medicare. MDH discussed how these patients might not be aware they qualify for Medicare, and so the report included a review of other states on eligibility policies for this group and found that some states do require Medicaid participants with this diagnosis to apply for Medicare as a condition of continuing their Medicaid coverage. MDH plans to expand outreach to this group and encourage more applications to Medicare. That is described on page 45. It includes notices by mail and follow-up letters. And so considering these outreach activities, MDH is asked to provide an update on the timing and how this effort would be taken, and then whether there could be other conditions that could similarly be eligible for Medicare coverage. DLS recommends reducing the allowance by $3 million in general funds and the associated federal match in anticipation of the savings from these efforts from encouraging more people to enroll in Medicare if they're eligible. So I will talk about the recommendations that begin on page 47. A lot of these already came up in the presentation, so I'll just cover the ones that haven't been discussed already. Items 3 and 4 are the annual budget language that restricts the Medicaid and Maryland Children's Health provider reimbursement budgets to that purpose. It does allow for transfer over to the Medicaid behavioral health provider reimbursements. Item 5 would restrict funds pending a report on the Community First Choice Program and Community Options Waiver spending and registry. And then item 6 has to do with the latest OLA audit of the Medical Care Programs Administration. The corrective actions were found to have not been fully implemented, and so this would restrict funds pending a letter from OLA confirming that the corrective actions have been taken. I believe everything else has been mentioned in the presentation, and so with that, I will conclude. I'm happy to answer any questions.
Thank you so much, Ms. Braun. Do any subcommittee colleagues have any questions for our analyst? Okay, seeing none. Thank you for your really thorough and thoughtful analysis. 71 pages, y'all. Was a little bit of light reading yesterday for our committee. Thank you so much. We'll now invite our Secretary of Health and Deputy Secretary and team to join us for their presentation. And you can begin when you're ready.
Great. Thank you. Good afternoon, Chair Shetty and members of the Health and Social Services Subcommittee. For the record, I am Dr. Mina Seishamani, Secretary of Health for the state of Maryland. The department thanks the governor, the Department of Budget and Management, and the budget committees for their support. And we thank the Department of Legislative Services for its insightful budget analysis of the medical care programs, otherwise referred to as the Maryland Medicaid Administration in the Office of Healthcare Financing. I'm pleased to be joined today by Deputy Secretary Perry Briskin and members of the Medicaid team to discuss the fiscal year 2027 budget. Across MDH, we are working to improve health across the lifespan, and Maryland Medicaid, as one of the state's largest and most vital public programs, is a cornerstone of this work. Today, however, the program faces significant fiscal pressure and increased federal scrutiny. And in this environment, our focus is straightforward. Do the basics well. Ensure Marylanders can get coverage, keep coverage, and access coverage when they need care. For Maryland Medicaid, the proposed budget provides significant investments with $13.8 billion in total funding for delivering health care to more than 1.4 million Marylanders, including 197,000 children through the Maryland Children's Health Program. It includes no provider rate cuts or benefit cuts. So 3 key areas that I want to highlight for all of you. First is implementation of HR 1. To improve health across the lifespan, the budget supports implementation of the various requirements under HR 1 as we work to protect Marylanders from coverage loss and service disruption. And in response to the new federal Medicaid provisions, Maryland is investing 13 million general funds across fiscal year 2026 and 27 for staff and information technology solutions that are needed to protect access to care. The second area that I want to call attention to is eligibility processes and systems. The budget supports our ongoing work to improve our capabilities to verify eligibility, process redeterminations, and ensure access to needed Medicaid services and benefits for current and future enrollees, including those served by home and community-based service waivers. And the third area that I want to highlight is our audits. The department is committed to operational excellence and ensuring the fiscal stewardship of taxpayer dollars to support quality care. The department takes OLA findings seriously, and we are implementing a new process to implement corrective action, not only within our Medicaid program, but across our department as well. So overall, thank you for providing me with an opportunity to highlight a few areas from the Maryland Medicaid Administration and the work we do to continue to protect Marylanders. We look forward to working with you, the Maryland General Assembly, with advocates, and with the community as we pursue our collective vision of a high-quality healthcare system that produces the best possible health for Marylanders across their lifespan. I'll now turn it over to Deputy Secretary Briskin and her team to address the specific budget questions that are in the DLS analysis. Thank you.
Thank you, Secretary. Good afternoon, everyone. Thank you for having us here today. I am joined at the table by Maryland Medicaid's Chief Financial Officer, Jen Mayer, and Maryland Medicaid's Director of the Program Innovation, Research, and Development, Alyssa Brown. My name is Deputy Secretary Perry Briskin, and I am the Maryland Medicaid Director. I will now go through DLS's questions and Q&A. Starting with the Maryland Department of Health should discuss why the annual Population Health Incentive Program PHIP report was not available yet and brief the committee on MCO's measurement year 2024 results. That report was finalized on February 13th, and we have sent that to DLS, and it's posted on our website and linked for you in our answers. For measurement year 2024 performance in PHIP, the Health Choice MCOs earned 62% of available round 1 incentives. And to earn round 2 incentives, MCOs needed to earn at least 80% of round 1 incentives, and no MCO reached that threshold. However, 2 MCOs earned 79% of available round 1 incentives. The next question is MDH should discuss reasons for delay in processing non-MAGI cases and comment on the feasibility of reporting monthly application processing measures that show the number of applications processed in more than 45 days by MHBE and 90 days by DHS. I would like to start by flagging that our non-Magi population is a total about 260,000 individuals in what we call our aged, blind, and disabled group. The number of members in just the home and community-based services waivers is about 30,000 individuals, and it is for those HCBS waivers that we are seeing the greatest delays. For those waivers, we know that many different entities and systems are involved in those approval processes, from DDA, Maryland State Department of Education, BHA, OLTSS, as well as DHS. So the DHS number that you see in our quarterly eligibility reports captures the total number for that 260,000, and that is where you get an average of 15 days. It doesn't specifically capture that smaller, just waiver HCBS group. The primary reasons for delays in processing the HCBS waiver financial eligibility by the Eligibility Determination Division, EDD. Number one, IT system limitations. So non-Magi financial eligibility determinations are processed in the eligibility and enrollment system, while medical and technical eligibility determinations are processed in LTSS Maryland. Limited system functionality leads to interoperability issues and reliance on manual processes. MDH is working closely with our partners at Maryland Benefits to make improvements and enhancements to this E&E system so that more of those pieces of the process can be automated and require less manual touch. I'm sorry, my nose is sniffling a little bit that time of year. Data and reporting limitations. At this time, E&E, the eligibility and enrollment system mentioned, is not configured to routinely produce operational reports that track application processing timelines, including the number of HCBS waiver applications exceeding 45 and 90 days. However, just this month, after sustained effort, we were able to get our Hilltop partners access to the E&E database, and we hope that they can start producing these reports shortly and that we can share them with you, and also consider putting out publicly some of these metrics, because we know that's a strong desire from many individuals. Staffing constraints. There have been admittedly staffing challenges within EDD, OLTSS, DDA, and other waiver administrating agencies that have resulted in application backlogs, limited training capacity for staff, and delays in completing eligibility actions that are interdependent across agencies. We are working to fill every PIN that we have access to, as well as to search for other resources in the department and beyond to bring in details to address the backlog and address root cause issues. The next question is in regarding DLS's recommendation to reduce the fiscal 2026 deficiency for prior year service costs by $70 million, including $10 million general funds, based on year-to-date actual carryover spending. Following this reduction, the deficiency would still provide approximately $12 million in general fund support beyond current estimated need. This is from page 14 of the analysis. The Maryland Department of Health respectfully disagrees with the DLS recommendation to reduce the FY26 deficiency supporting service year 2025 carryover claims. Provider behavior with respect to claims submissions is difficult to project. While it is possible that $12 million general fund would be enough to address remaining carryover claims, it is far from certain. Last year, the Medicaid program paid $22.7 million general fund and carryover claims from February through June for service year 24, and the year before that, the program paid $31.8 million general fund for service year 23 carryover claims during that period. If the program were to exhaust the carryover claims budget before all prior year claims are paid, those costs would be applied against appropriation budgeted for service year 26 program costs. Stretching the current year appropriation to the point where it cannot cover all current year expenditures would expose our department to a repeat audit finding. We therefore ask that rather than impose a negative deficiency, the General Assembly allow us to work with DBM to make this item a targeted reversion. Next, MDH should provide an update on the negotiation with CMS related to the nursing facility rate disallowance and how this would be resolved without additional payment needed from the state. Additionally, MDH should clarify how much is outstanding in the very low birth weight, VLBW, payments to MCOs. First, on the nursing facility rate disallowance, Maryland Medicaid is currently in discussion with CMS about a budget-neutral path forward by the end of fiscal year 26 that can account for this rate increase without any additional penalty to Maryland. We are currently in the midst of meeting with CMS and hope to have an update with more details on that path soon. Regarding very low birth weights, the amount outstanding of those payments due to MCOs is estimated to be $1.2 million total fund for claims prior to fiscal year 26. And we acknowledge we're also working to better staff that area that manages those payments so we don't get to this backlog in the future. Next, DLS recommends reducing the fiscal 2026 deficiency appropriation for Medicaid provider reimbursements by $151.4 million to account for the MLR recovery received in fall 2025. MDH respectfully disagrees with DLS's recommendation to reduce the current year budget to account for MLR recoveries received in fall 2025. The MLR recoveries are a one-time item among dozens that push the Medicaid somatic services budget in the direction of deficit or surplus, rather than make such a large reduction to the budget based on this one item and in light of potential budget drivers that could push this particular budget into deficit, and to provide flexibility should other areas of Medicaid require budget support post-session, we ask that this reduction not be taken. Next, to ensure that the cigarette restitution fund appropriation is not provided twice, DLS recommends adding budget bill language to make this funding contingent on enactment of this BRFA provision. We concur with this recommendation. DLS also recommends amending the contingent language regarding CHRC funding mandate as a technical correction to more closely align with the applicable provision in the BRFA. MDH also concurs with this recommendation. MDH should provide an update on any federal guidance or notice it has received in regards to provider assessment policies, including whether the department is planning to make any changes to gain CMS approval to meet uniform and broad-based tax requirements. CMS issued a final rule on provider taxes on January 29th, 2026, effective April 3rd, 2026, that implements the provider tax revisions under HR 1, otherwise known as OBA. Under the final rule, CMS prohibits provider taxes that impose higher effective tax rates on Medicaid services or enrollment than on non-Medicaid activity, that tax providers with higher Medicaid volumes at higher rates. So CMS is revising its framework, clarifying that non-uniform provider taxes are no longer automatically approvable based on statistical tests alone. The rule also establishes transition periods for bringing states into compliance. Maryland has an MCO tax, a nursing facility tax, and a hospital tax. The MCO tax would need to be brought into compliance by January 1st, 2027, while the hospital and nursing facility would have to be brought into compliance at the start of fiscal year 29. MDH is currently reviewing its provider taxes with CMS, and we request direct CMS technical assistance to understand if and how our taxes need to be, or as we call them in Maryland, our assessments need to be changed in any way. But the answer is yes, the department would of course be open, depending on what CMS requests, to making adjustments in order to maintain the tax. And as DLS mentioned, those adjustments would most likely be around broad-based. Are we taxing all providers in the class of providers? Next, DLS recommends reducing $3 million in general funds budgeted in DBM for health reimbursement accounts of certain state retirees transitioning to Medicare Part D in anticipation of an equivalent SPDAP fund balance transfer. This reduction will appear in the analysis for F10A02 DBM personnel. MDH will refer to DBM's response to the F10A02 DBM personnel budget analysis. MDH acknowledges that the current SPDAP revenue balance can support the proposed $3 million alignment to DBM. However, given recent and upcoming SPDAP revenue transfers to the Behavioral Health Administration for community mental health services, $10 million across FY25 and FY26, and to DBM for health reimbursement accounts for certain state retirees, $3.1 million FY25 and FY26. The SPDAP's ability to implement new program benefits or benefit levels in the future such as increasing the current premium subsidy benefit in future years or providing a subsidy to help SPDAP enrollees partially offset their Medicare Part D prescription drug plan deductible costs becomes problematic. Uncertainty regarding potential future changes in SPDAP enrollment, unknown future fluctuations in market Medicare Part D premium costs, and SPDAP fund transfers could leave SPDAP underfunded in the future. Continued realignment of revenue might force the program to implement a waiting list for new applicants or decrease current benefit levels for enrollment. Next, MDH should provide fiscal 2026 year-to-date spending from the Maternal and Child Health Population Health Improvement Fund and describe why eligible programs under Medicaid and FIPA underspent the appropriation, leading to a large fund balance. Additionally, MDH should clarify how it will spend the remaining fund balance and should work with DBM to adjust fiscal 26 appropriation and fiscal year 27 allowance through a supplemental budget to accurately reflect planned spending in each year. So for 2026 year-to-date expenditures, as of the end of January, beginning of February, between both Medicaid and the Public Health Administration, expenditures are around $762,000, which projected for fiscal 2026 to be $2 million. Regarding within Medicaid, the fund supports Medicaid doula coverage, home visiting, centering pregnancy healthy steps program, and maternal opioid misuse mom services. We expect that the rise in the costs will continue to increase. What we spend will continue to increase due to the 12-month claims run out for all providers. It is important to note that the department will continue to provide these services and will continue to promote these services. As with all new services, we can see it can take up a few years for sufficient uptake. But we do want to point that we have done significant work to support individual providers and our MCOs in adding these new services and educating our members that they exist. So just as a few examples, we have coordinated and collaborated with local health departments to improve provider completion and timely submission of Maryland prenatal risk assessments to the LHD and MCOs. We have contracted Medicaid enrolled doulas, implemented a referral workflow, increased enrollee engagement. Also have done similar things to expand the doula and home visiting network of providers. And we have increased the number of identified pregnant enrollees with substance use disorder and integrate workflows to increase the number of identified pregnant SUD enrollees into enhanced case management. And we will continue to do this work to promote these services. And once this fund is depleted, these services do not go away. These are Medicaid benefits, so we would continue to fund them regardless of whether this fund exists, but this fund will exist through 2027 when it's due to sunset. MDH should brief the committees on the need for this pharmacy services system project, including the planned project schedule. Additionally, MDH should clarify whether the MITDP will also support other pharmacy services provided by FIPA. DLS recommends reducing $1.35 million in general funds budgeted in the Information Technology Investment Fund within DO-IT and authorizing a budget amendment to replace the funding with federal funds to account for expected federal fund participation for 90% of this project. MDH is pursuing the pharmacy services system project related project to replace the current conduit pharmacy benefits management system contract or pharmacy point of sale electronics claim management services. The conduit pharmacy contract expires June 29, and starting this new project now provides MDH adequate time to complete the procurement process and implement the new system. MDH is currently drafting the request for proposal to solicit new claims and benefits management system. Pharmacy services provided by the Prevention and Health Promotion Administration, FIPA, are intended to be included in the RFP, including kidney disease program, breast and cervical cancer diagnosis and treatment, and the Maryland AIDS Drug Assistant Program. Fiscal year 27 MITDP should reflect the 90% project support through the enhanced match for Medicaid. More recent cost estimates, however, lead MDH to believe that overall project costs in fiscal year 27 will run closer to $2.5 million rather than $1.5 million, which would require $250,000 of state share. We therefore request that the Information Technology Investment Fund budget associated with this project be reduced by $1.25 million rather than $1.35 million recommended by DLS. We request that this $1.25 million be realigned to support the state share of the fiscal year 27 project costs associated with another MDH Medicaid MITDP, the provider management module, to better align with projected expenditures. The provider management module also has a new name called M-Prime, and you will be hearing a lot more about M-Prime. It's set to go live this October. MDH should describe any outreach methods that it used to inform Medicaid participants that services received from Planned Parenthood would not be covered through July 4th, 2026. This is the provision under H.R. 1. Maryland Medicaid notified all 9 Health Choice managed care organizations that services provided by Planned Parenthood would not be covered under the Health Choice program through July 4th. Consistent with established health choice requirements, MCOs are responsible for communicating coverage changes to enrollees, including provider network changes. MDH conducts oversight of MCO member communications and ensures compliance with contractual requirements. In addition, MDH has communicated with providers and stakeholders regarding the coverage limitation to support appropriate referral and continuity of care. Separately, MDH notes that Planned Parenthood affiliates in the Metro DC region have received replacement funding and support and may continue to provide services outside of Medicaid coverage. Next, MDH should comment on feasibility and timing of using data sources to automate and verify work requirements and exemptions under H.R. 1, including data sharing policies that are already in place and ways to ensure data security of all program participants. We are in touch with many state agencies, federal agencies, and other data sources to identify and create new data streams to further automate and verify work requirements. These include, first of all, SNAP. As DLS mentioned, we already work closely with the SNAP program on express lane eligibility. So we already use SNAP data to validate Medicaid participants. In addition, MDH and DHS are working together to augment that data feed to include individuals who are subject to SNAP work requirements. So if you qualify for SNAP work requirements, you would also qualify for Medicaid work requirements. Next, wage and workforce development data from the Maryland Department of Labor. MDH, through Maryland Health Benefit Exchange, our close partners on these determinations, uses wage data from Department of Labor. Further conversations are underway to determine how workforce development data can be shared to verify work requirements. MDH, DOL, and MHBE currently meet bi-weekly to continue work on this topic. We are also actively looking at CRISP, the Chesapeake Regional Information System for our patients platform, to use CRISP data to automate medical exemptions for individuals so they can be exempt from work requirements. So through existing data sharing agreements, CRISP has access to all Medicaid claims. Conversations are underway to create a new API to enable MHBE to receive a medical frailty flag in the system for applicable applicants. Education and workforce data from the Maryland State Department of Education, and we are looking into a data sharing agreement to for direct certification of students for free and reduced price lunch eligibility. MDH has determined that the National Student Clearinghouse has more comprehensive data that might be able to determine a student's status to be exempt from work requirements. So we use MSDE data for free and reduced price lunch eligibility for children, and then for adults who are in university part-time, we're actually looking to use the National Student Clearinghouse. We're also in discussions with CMS for them to make the National Student Clearinghouse data accessible to all states, so Maryland doesn't have to go at that on their own. Lastly, tax return information from the Comptroller of Maryland. MHBE uses tax return data from the Comptroller already for the Easy Enrollment Program. MDH, MHB, and the Comptroller's Office have met to discuss if there's further utility for this information and other data. Next, DLS recommends adopting narrative requesting 2 reports on OBA implementation. We concur with this recommendation, and we also just want to note here for the record that we do on a quarterly basis through JCR's already report a list of eligibility measures quarterly to the General Assembly, and this follows our monthly reporting of these measures during unwinding. MDH should provide a status update and timeline for implementation of new outreach strategies and requirements for Medicaid participants in the end-stage renal disease ESRD diagnosis to apply for Medicare. Additionally, the department should discuss whether there are other conditions or diagnoses that would qualify Medicaid participants for Medicare and should be included in these outreach efforts. In fall 2025, we launched an initiative to connect participants with ESRD who appear to be categorically eligible for Medicare to apply for Medicare coverage. We have contacted participants by mail with information to guide them through the process. We included contact information for where they can go and get that support. We are dedicated to building partnerships with providers and state agencies to further encourage Medicare enrollment of ESRD patients. MDH plans to issue a transmittal in March to encourage providers delivering services to ESRD patients to help them get onto Medicare. So we are leaning on our providers to support that work. And there are discussions internally of what additional actions the department can take to push more people to sign up for Medicare. We have seen about 20%, since we've started, about 20% of those who received the letter start to apply for Medicare, but only 4% of those individuals have actually finished the enrollment process. MGH respectfully, so next point, and I think this is, bear with me, the final one. DLS recommends reducing $8 million, including $3 million in general funds in fiscal year 27 to account for savings from Medicaid participants with ESRD enrolling in Medicare as a result of MDH's outreach efforts. MDH respectfully disagrees with this recommendation. MDH acknowledges Medicaid's role as a payer of last resort for ESRD services and is working to implement this initiative to leverage Medicare eligibility, but at the same time we must balance the need to maintain coverage for those with ESRD through the implementation period. Full implementation, and I think this is a discussion of whether we make it a mandate rather than a suggestion that you go to Medicare once you are eligible. Full implementation of that would require additional operation build out within Medicaid eligibility systems. MDH is continuing to work with the Hilltop Institute to provide an analysis on the success rate of the letters where we suggest that people transfer. And then we are, as I said, continuing to have discussions internally of what additional things we can do to move people to Medicare. And with that, I conclude the Q&A of the DLS analysis, and we welcome your questions. Thank you so much.
Thank you so much for your presentation. Colleagues on the committee, I'll let you guys take the first bite. Delegate Heimbaugh, saw your light first.
Thank you, Madam Chair. Thanks for that very thorough response to the report. I also want to thank you because of the critical nature of the services that your organization provides. I deeply appreciate that. And on page 39 of the report, under personnel data, it shows that you have, if I'm reading this correctly, about 94 vacancies and a vacancy rate of 14%, which seems kind of high compared to some other organizations that we've seen come through. And I think maybe more concerning to me is, again, if I'm reading this right, you're getting 46 additional positions, and the vacancies you have, 21 of them have been vacant for more than a year. And I'm concerned with the additional workload that you have a lot of vacancies already. And I'm just wondering, the 21 that have been vacant for over a year, is that because of the skill that's involved or the pay that's involved, that it's not competitive? Why are you having such a difficult time filling those 21 positions?
Thank you for that question, Delegate. I asked my team the same question. I will provide an answer, but I would love to get you some data and take that for the record. But I will say initially, one, we have been under a hiring freeze since last fall, so we have not been able to hire as much as we can, even though we're pushing forward a few exemptions. Some of those positions are difficult to fill due to the low salary. And some of those positions, the HR processes can take a long time. So it can take sometimes 6 to 9 months to get through all the steps in the process to fill a position. So that would be my sort of subjective guess as to why that is, but we can actually get back to you with a little more detail and data on that point.
If I could, just curious, 6 to 9 months to hire somebody from the time you identify who you want to hire, it still takes 6 to 9 months, or the recruiting is included in that?
The recruiting is included in that. So from developing the posting, if we need to rewrite the posting in any way, or as we say, reclass it, move it around, to getting that approved, to posting it, to interviews, the entire process.
So could you speculate a little bit on the vacancy rate and what do you see the vacancy rate declining over the next year then, or?
We are working very hard to make sure it declines, and especially for the eligibility positions that are included in the budget, we will make every effort to fill those. We also recently did, DBM recently approved an equity salary request for some of our lowest paid workers in our eligibility services that we hope will also help with that.
Okay, thank you. Thank you, Madam Chair.
Thank you, Delegate. Delegate McCaskill.
Thank you, Madam Chair. My colleague's opening remarks made me a little misty, and I had to pull out my tissue. That was so nice of you. Hello there. Wonderful, thorough, never took a breath, seemed like
Maybe I should
response, so I think it's a record as well. I'm quite impressed. As you know, I'm a member of the Legislative Black Caucus, and one of our priorities has been, and still is, but we passed a bill in the past around biomarkers. So I just want to focus on that just for a second. As you indicated on page 29 of the DLS analysis, as indicated on page 29 of the DLS analysis, it's great to see the efforts that MCPA has taken to implement biomarker testing for diagnosis, treatment, and monitoring of diseases like cancer, heart disease, and perinatal health. What efforts is MCPA taking to ensure biomarker testing is made available and accessible to Medicaid beneficiaries?
Thank you for that question, Delegate McCaskill. Yes, we have been very proud and excited about the expansion of biomarker testing, and then it was further expanded last year. So, like with all of our services, when we have a new service or an expansion, we do a provider transmittal, we promote it with our MCOs. I think we also want to monitor it in the data and see the uptake. We meet with stakeholders, so we are engaged with this and are prioritizing that, but I would be happy to go back to my team and get more details on all that they're doing and pull some data for you so you can see, and maybe we can brainstorm on some better ways to promote it. I think not dissimilar to the maternal health services, it's sort of when Medicaid puts out a new service, how do you promote uptake, and there are many different ways to do that.
Thank you so much, because we know that we serve, we have a lot of health inequities across our communities, and so it would be nice to have that. In addition to biomarkers, I'm still there. What measures will MCPA implement to ensure biomarker testing data is secure and maintained to protect the confidentiality of Medicaid participants?
We do everything that we can under our authorities to protect all Medicaid data of our participants. I will say, unfortunately, we've seen a federal government who is not as interested in that effort. We are part of, I believe, a multi-state litigation that is challenging CMS's use of Medicaid data for non-Medicaid purposes, specifically in the immigration side. But we will continue to, we have many mechanisms in place to protect data. we do, under CMS regulations, have to report a significant amount of data, including PII, up to the federal government. So that's something we're continuing to keep a close eye on in terms of how the federal government is using it and what the federal government on its own, without Maryland's permission, is releasing. But we have a number of mechanisms, and we can also get back to you in more detail. We have many memos on exactly how we protect our member data, both under federal and state statute.
Perfect. We'd appreciate that because we know that a lot of times our patients can be reluctant to seek services if they don't feel that confidentiality is of a priority. I want to switch to HR 1, if you don't mind. We appreciate the timely effort that MCPA has taken to quickly adapt to federal provisions on work requirements. I'm sure it's been a tremendous overhaul for you all. On page 43 of the DLS analysis, give you a second. Perfect. We understand that you are formalizing guidelines this summer after CMS provides its guidelines in June. However, do you have any early insight or indications into how these work requirements will impact caregivers, medically frail people, pregnant women, and families?
Thank you for that question. While I have the opportunity and the floor, I would like to recognize Alyssa Brown and her team, who has been leading all of our OBA and HR1 implementation and been doing a tremendous job. So
Nice, that gives you a break.
So in the HR1 statute, there are exemptions for those categories that you detailed. So I think where it will be for the state to execute is making sure that those exemptions can be as automated as possible with existing data. So we want to reduce the data burden on our members and on our staff as much as possible. So that is where CRISP data comes in, other sources of data. We do expect CMS and their guidance that is forthcoming to put more detail on how we can make those exemptions, who exactly can qualify. But we do not have time to just sit around and wait. We're doing the best we can with what's in the statute, and then we'll make tweaks once CMS guidance is released. But given what we've heard from CMS verbally in various forums, we believe we're on the right track. But we just want to make sure things are as automated as possible. Secretary, I don't know if you wanted to add anything to
No,
that.
I think that's right.
Perfect. Okay, we appreciate that insight. And so, Madam Chair, if I can take one last bite of the apple. Perfect. Still at HR 1, federal policies increase the frequency of eligibility redeterminations and new work requirements. Can you explain in detail the efforts MCPA has taken to address these administrative tasks and how it will impact current workloads for your staff? And how does it tie into the new contractual full-time positions within the Office of Eligibility Services that is mentioned on page 39?
Yes. So the more frequent eligibility checks, so going from every 12 months to every 6 months for the ASA adult group, will increase the number of applications that are coming through the system. So there is, for each of those adults in the ACA group, they will have additional work requirements to attest to, as well as they will have to go through it twice as often as other individuals. So we do expect a rise in the number of applications that our teams have to process. I think number one, again, is how do we update our systems to make things as automated as possible? So how do we make sure, right now we have about a 55% automatic renewal rate, redetermination rate, which means 55% of our applications can get through the system by just technology, using existing data the government has already collected from individuals. How do we increase that rate and make sure that the work requirement auto renewal rate is at a similar high level? For those individuals that don't get through the automatic return, the automatic renewal process, those individuals have applications that do require an eligibility worker touch on it in some capacity. The Office of Eligibility Services that is receiving a lot of the new positions that you mentioned, they are primarily responsible for developing the policy around all of these changes, developing training, developing oversight of many other eligibility workers in the system. And so those workers are critical to make sure we are implementing things correctly. I will also note in Medicaid, the error rate that is given to a state by CMS is largely based on how are we determining eligibility and if we have all the paperwork to say we did this correctly. And so a large part of what the eligibility services team will do is making sure that we keep Maryland's error rate below the national average where it currently is. Because we know that fiscal penalties, not dissimilar to SNAP, are coming as part of HR 1 for Medicaid error rates starting in 2028, 9, 20, somewhere around there. I have checked 2028 or 2029, but we are keeping a close eye on that as well.
You taking a breath? You sure? Okay, I just wanted to make sure. Thank you, Madam Chair, and thank you. And you finished just in time because I literally just got called for my hearing. Thank you.
Good luck in your hearing, Delegate.
Thank you.
Delegate Stanka, you had your mic earlier. Are you ready to go? Yes, sir.
Thank you. Thank you, Madam Chair. Just want to touch back on the questions from Delegate Heinball and the 6-month period. So just a clarifying piece for me. In that 6 months, imagine you identify a candidate. That candidate's name is Jim. He's a really decorated Army veteran. How long does it take you from once you identify that person to get to the aspect of like getting them an offer in their hands?
I would have to confirm off the top of my head, it's about 3 months.
Okay.
And that is between, we have to, Jim may say he's a decorated Army veteran, but we want to verify and vet that he is a decorated Army veteran and vet his, our candidates go through vetting, there is salary negotiation, there are a number of different things that have to take place once we finish an interview and select a candidate.
How often in that process does you identify this candidate you really like, that candidate, because the length of time that it takes, you end up losing that candidate to some competitor, and that could be private or public sector?
Not infrequently.
Could you give me is it?
Well, and I actually think this relates to what Deputy Secretary Briskin flagged earlier, that we have gotten from DBM the opportunity to raise the salaries, particularly in our eligibility area, because that is where, to Delegate Heinbaugh's point, this is multifactorial. And there's the hiring freeze that has led to us not being able to hire where there are vacancies. There are issues with having a competitive salary, and also that competitive salary both impact being able to hire someone, but then also the turnover. And as you know, turnover then contributes to a vacancy rate.
And more turnover, right?
So that is, I would say, where we have been identifying where there are those examples of where we need to try to make our salaries more competitive.
Appreciate that. And I think the once upon a time in my career, I was in a job where, my job, I managed about 150 people that reported up to me through different layers. And, I was in the role where I would take like the management's goal of efficiency, call it like the C-suite goal of efficiency, right? And then the people that reported to me, they had employees. And my job was to be the difference of like what actually happens at the operational executional level and what that goal of efficiency was, right? And one of the things that I always ran into was in that efficiency, you'd have this view of let's say there was 10 people in this team, and it was getting done with, the work was getting done with 8 people, and there was almost always 2 vacancies. And inside of that 8 people, you look at the calibration, you're like, we're doing great, we're doing it with 8 people, things are going well, and so we could do this with 6 people, right? And not by laying someone off, but in natural attrition or someone transfers out. And then what ends up happening is you end up with the two additional vacancies all the time, right? And so you end up in this kind of like disconnect between, and I think this isn't like with you all, but like at a thing about AFSCME that comes often, like you hear this disconnect between labor and management, we'll put it in that way. And so one of the things that I always kept in mind and have pushed folks to think about is the time, how do you maximize or I guess really how you maximize your execution, but minimize the time between identifying the candidate that you like and getting that person to an offer as fast as possible, so that you don't lose that person, whether because they're unhappy with their current employment or to that competitor, they were faster to offer, right? Because they were able to background check quicker, check for credentialing. And then it ends up being, because that person comes in faster, the broader of that reduces creating an upward spiral versus a downward spiral. And so that was why I wanted to get a view of like, you know, one of the things I'm always pushing for is like, what things can we get out of the way that delay that time? Or even in that level, if I interviewed candidate Jim and I liked him, and then the next week my manager's on vacation, the week after that their manager's on vacation, and it's a month before that person comes back in, and by the time they've accepted that other job offer, they're like, I gave my word, I've committed, like if this came a month quicker, I probably would have done it, but it's too late, and now you're back to square one. So just wanted to get clarity. Thank you.
No problem. Delegate Heimbaugh.
Just
Candidate Jim.
Well, this is interesting to me, but especially the personnel part of it, but just real quick. I mean, hiring new people is one thing, but you touched on turnover, and that's what the killer is, because you lose people that you've invested in training and have experience. So I assume you're looking at
And that's why we put this forward with DBM, particularly in this area, because this is where we found that there was turnover, and that's why we worked with DBM to be able to prioritize this as an area to raise the salaries. Exactly.
Thank you. Thanks to my colleague for using me as an example, too. I appreciate it.
You would pass vetting, Delegate, don't worry.
Great, thank you. Delegate Ruff, I can't see if your microphone is on. No, okay, sorry. It's very difficult to see over here. Thank you. I have several questions. So I'm going to start with Medicaid enrollment trends and forecasts. So Exhibit 16 on the DLS analysis shows that there's going to be a drop in Medicaid enrollment for parents and caretakers, non-citizen pregnant women, and in MCHIP. So I'm really concerned about the drop in enrollment, especially that pertaining to HR1 and the categories that are no longer eligible. I want to ask if you have any thoughts yet on where those parents, caretakers, non-citizen pregnant women, and uninsured children will go to access health care.
So I can start with this. I think first, to get to your concern, Chair Shetty, we want to make sure, and it is our top priority, to keep people who are eligible for Medicaid and enrolled. And I think that what you heard from Deputy Secretary Briskin is that that is a combination of being able to leverage our technology and draw in data sources so that where there are people that can have exemptions, that we are automating that so that if there are people dropping out, it is not because there are these undue barriers that they have to be able to stay enrolled. I think given, we have to also prepare that, there could be some people who do come off. I do think that we will continue to partner with our FQHCs, and we also want to continue working with all of you as this develops, because remember, again, this will go into effect January 2027. We are preparing for that January 2027. Let's try to automate as much as possible, and remember that something that Deputy Secretary Briskin was referring to, we have room to potentially improve our auto renewals across the board, not just with this ACA population that is being affected by a lot of the HR1 requirements. So that can lead to improvements that can then help us to specifically address where there may be people who come off the rolls right now, because we're going to be able to, if everything that we want to do we're able to do, that we are able to improve processes overall. So I think these are the areas that we would really appreciate continuing to iterate with all of you on.
Okay, I appreciate the response related to ensuring that those who continue to remain eligible are able to continue to receive coverage. And I'm wondering if you might speak to whether there might be some role that healthcare navigators could play in supporting those efforts.
Actually, I will say before coming here, I was speaking with faith leaders in Black and brown communities, and this was actually an area that we were talking about. I think it is going to be incumbent on all of us to make sure that we are reaching those in our communities as they are navigating, right? We can set up more automated systems, we can get information out on what are the exemptions, et cetera. We also have people on Medicaid who are trying to hold down their jobs, they're trying to pay their bills, they're trying to deal with everyday life, and so it's going to be very important for us to really meet people where they are, and also to emphasize that people shouldn't say, oh, well, now there are cuts coming to my coverage, so I'm just not going to be eligible anymore, when in fact, we want to make processes and systems work to keep them eligible. And in fact, talking about the insurance navigators came up in our conversation today as one avenue for that, where in particular, in partnership with community leaders, like for the example, the faith-based leaders that I was talking with today, that we have an opportunity to connect that for people.
Okay, great, thank you. That's really helpful. I want to turn to page 22 of the DLS analysis, please. First, I want to thank Deputy Secretary Briskin for the ongoing conversation around the nursing home quality assessment fee, which has become quickly my favorite topic of conversation with the department. So on Exhibit 8, it notes that the 2026 appropriation working and the 2027 has $162.4 million and $164.5 million noted for that fund. And I'm just curious if you can speak to whether these numbers are projected numbers, similar to the 190-something that was projected in the FY25 report that was posted online.
Yes, Chair, these are projected.
Okay, thank you. And then per the information you shared with me earlier this week, you noted that only about 171 million was collected of the projected 193 for FY25. And I'm curious if you see a similar delta in collections, where would that likely come from?
So we know that, and I think this is also, I mentioned very low birth weight, making sure that we are issuing payments. We want to make sure we're collecting payments from all our nursing facilities, so we're working with that. The nursing facilities, I think I mentioned to you, have until the next fiscal year to fully pay their assessments, so sometimes the timing can get a little wonky.
And a 60-day window or something like that,
Yeah.
post-invoicing?
Exactly, and we do have a few providers who we have been struggling to, or not struggling, but have been late to pay their assessment, and so we have been approaching them as well.
I've also heard from providers that they've not received the invoices at all from the department for these assessments in some instances, so I'm curious if you're hearing the same.
We have been hearing that historically, and that's something that we have tried to correct. Our CFO, Jen Mayer, has been working very hard on that. Jen, I don't know if there's anything you want to add to those efforts, but we have seen that there was a delay for some years in us seeking out those payments, and we're working to correct that.
Yes, absolutely. Thank you for the question. We are working and improving our processes. I think there was a turnover in staff which required, or which caused a delay in the letters going out, and then it created a backlog. And so as of, I would say, last quarter, we feel that we're moving in the right direction to get those letters out timely. So we have 60 days to collect. Day 61, if we don't have the collections, the letters should go out.
Got it. And could it be possible that the backlog is partially responsible for the nearly $20 million in delta in the projected collections for FY25 versus the actual amount collected?
It could potentially be, yes.
Okay.
We're working on a reconciliation between the projected 191 and the 171.
Okay, got it. Thank you. That's really helpful. I want to turn, please, to the ESRD program. I am really excited about the information shared in the JCR, or as a result of the JCR, on how MDH could potentially maximize best quality of care for end-stage renal disease patients while also ensuring that federal funding is utilized when possible. So first, I want to note, Madam Deputy Secretary, I sent you a letter on January 20th of this year related to ESRD patients who reside in skilled nursing facilities who are receiving dialysis treatment, and a question related to transportation costs. I'm wondering if you have received it to date. I have not received a response, and I'm wondering if you can share today any information on that, or if you're able to share an estimate of when we can expect a response, please.
You will get a response by the end of this week. We have received it, our team is working on it, and we will make sure to get your response this week.
Thank you, I appreciate it. Second, I want to ask a little bit more about, I really appreciate that the department is reaching out to potential beneficiaries who could be eligible for Medicare, who are in end-stage renal disease and are able to qualify for Medicare, but are currently enrolled in Medicaid. I note that the Department of Legislative Services report noted that some states require patients, as they're applying for Medicaid, to first apply for Medicare. Is that something that we're considering doing? If not, is there something like a barrier in place that would prohibit us from making that kind of a policy going forward? I know it's challenging to do it with those that are currently in Medicaid, but is there a way that we can do that prospectively? Do you require a bill? What can be done?
I think I will say to what Deputy Secretary Briskin has flagged, we are absolutely facilitating the ESRD patients who are in Medicaid for, applying to Medicare. And, I think we can work with you on, are there things that we want to think about, moving forward. But I think what we want to do is make sure that people continue to have coverage as they make a transition. So,
Absolutely.
Yeah.
We want to make sure that 100% that they continue to remain covered regardless. But for those who are applying for Medicaid, who also have ESRD, is there a way that we could notify them or create a policy where they are simultaneously applying for Medicare, and then Medicaid becomes the default as it is in several other states? And so let's definitely continue the conversation offline so that we can reduce whatever barriers exist for patients. Okay, that concludes my questions for this panel. Thank you. We have, I think, 11 witnesses who have signed up. So as is their tradition of our subcommittee, please remain MDH team as our advocates share their thoughts on this budget. I will call down the individuals in the organization in which they are listed on my sheet, 4 at a time. Joseph Wynn with Maryland Managed Care Organization Association, Sarah Haregrove, Community Behavioral Health Association of Maryland, Kevin Lindemood, Healthcare for the Homeless, Carrie Cho, Cornerstone Montgomery. That's the first 4. 1, 2, 3, 4. Great. And you can begin once you all are seated. Thank you.
Thank you. Good afternoon, Chair Shetty and members of the committee. My name is Sarah Haregrove, and I'm the Assistant Director of Policy at the Community Behavioral Health Association of Maryland. CBH is the leading voice for community-based behavioral health providers serving vulnerable Marylanders. Our 95-member organizations provide essential mental health and substance use services to the majority of those accessing care through Maryland's public behavioral health system. As you've heard, the rollout of HR 1 will result in significant coverage loss for the ACA expansion population. Data indicates that expansion adults utilize mental health and substance use services at a higher rate than the Medicaid population as a whole. The population whose coverage is at risk is a population with a demonstrated higher level of need. Beginning in 2027, over 330,000 Marylanders will be required to comply with work requirements to keep coverage and will be subject to eligibility redeterminations every 6 months instead of annually. MDH is tasked with increasing staffing, training, communications, and operations to track and verify work requirement activities and exemptions, and will need to double the frequency of eligibility redeterminations. We appreciate MDH's proactive approach to ensuring continuity of coverage and respectfully urge the committee to support the department's budget request to ensure Medicaid can scale up operations to maintain Marylanders' access to critical health services. We also want to take this opportunity to acknowledge the remarkable progress made by Maryland's Behavioral Health Administrative Services Organization, Carelon, since their launch last January. While operational work remains ongoing, Carelon has demonstrated a strong commitment to supporting providers through a very complex transition. Carelon staff have consistently worked alongside providers to resolve a wide range of operational issues, approaching challenges with a collaborative spirit and a clear desire to support providers. We applaud Carillon's efforts to date and encourage the committee to support continued collaboration between Carillon and Maryland's behavioral health providers. Thank you.
Thank you so much.
Chair Shetty, members of the subcommittee, good afternoon. My name is Joe Wynn. I'm the Executive Director of the Maryland MCO Association. The Maryland MCO Association represents all 9 Medicaid MCOs that work to arrange and finance the care for 1.3 million residents in the state. We're a diverse group made up of hospital-led, provider-led, national and local MCOs, and I'm here on their behalf today to support the Medicaid budget. As the committee knows, Medicaid is the safety net for healthcare. Medicaid touches every community, every health system in the state, mostly moms and kids and working adults, but it's much more than that. In Maryland and throughout the country, it's a baseline that nearly 40% of all births are financed by Medicaid. About nearly 25% of the population is also covered by Medicaid, not inconsequential in any way. Medicaid operates as a partnership between states and the federal government. Maryland was amongst the very first states to engage in that partnership back in 1966, shortly after Medicaid was created. And Maryland is one of the most mature managed care programs throughout the country, with 30 years of continuous health choice operations, giving the state a leadership position that many states look to when they look to innovate their Medicaid programs. You will hear much about HR 1 today and the changes in OBA, and it's true. The state will need to make investments in order to deal with the eligibility and community engagement requirements, and there are other provisions in HR 1 that take effect later years, just requiring sustained investment in the program. Maryland's MCOs are proud to be partners for the state, and we continue to look forward to partnering on implementation of HR 1. And I'm here if you have any questions. My written comments are more substantive than my spoken comments. So thank you very much.
Thank you.
Good afternoon, Chair Shetty and subcommittee members. I'm Carrie Guthrie, the president and CEO of Cornerstone. Since 1971, Cornerstone has offered behavioral health services to people ages 5 and up in Calvert, Charles, St. Mary's, and Montgomery counties. We're one of the original CCBHCs in Maryland, supported with SAMHSA grant dollars, and we provide services across the continuum of care, from residential and case management to intensive in-home services for children, crisis, and outpatient services. I would like to add my appreciation that Sarah mentioned for the work that's been done this past year with BHA and Carillon. After the fiasco of Optum, it has been a relief to work with Carillon. While their transition has not been perfect, they've been incredibly responsive and collaborative. Cornerstone has actually addressed specific issues with them directly, and we've gotten resolution in a timely manner. So I just wanted to put that appreciation out there and support for continuing collaboration between all of us. As for HR 1, it certainly has the potential, as we know, to impact over 300,000 people receiving Medicaid in Maryland, and adults in this group will have to recertify Medicaid every 6 months instead of 1 year. Not only does that scare me for them, it also scares me for the staff that I have at Cornerstone who help many of our clients with recertifications, and also the state Medicaid agency. We have heard that they are requesting additional support. They're gonna need to manage a doubling in volume of documentation, tracking and verification for these recertifications, and adding the work requirements is gonna just add another level to that process. The state is gonna need to increase many things, a lot of resources to help address these changes. So we just wanted to say that we do support those departmental budget requests to meet these standards. Their resources will be integral to making sure that clients do not lose their Medicaid, that they maintain their eligibility and sustain their access to treatment that keeps them out of the hospitals and jails and homeless shelters. And it also ensures that agencies like Cornerstone will keep getting paid. I really am uncertain of how I'm going to budget for a churn of Medicaid that's probably going to increase. So again, just wanted to offer our support to the department and their requests. Thank you.
You are certainly not alone. Madam Chair, members of the committee, my name is Kevin Lindemood. I'm the CEO of Healthcare for the Homeless. We're a 40-year-old federally qualified health center working to prevent and end homelessness. We join the broader advocacy community in lifting up, as you will hear from many people, the need for additional enrollment support. for Medicaid to help people navigate new requirements and to help ensure that we are maintaining support for the most vulnerable among us. We're here in strong support of the Medicaid budget and of the Secretary and Deputy Secretary and their leadership team. Because of Medicaid, we at Healthcare for the Homeless can leverage grants and private dollars to ensure that everyone who comes to us for care gets the same care that they need. Here's an example of what we can do. Last year, a woman was in our waiting room to see a doctor and a behavioral health provider. And our dental assistant noted she had an opening in her schedule, and she walks out into the waiting room to see if anyone would like access to dental care. The woman says, "My goodness, I've not seen a dentist in 5 years. I would love to." And she stands up, and the astute dental assistant noticed that the woman was 8 months pregnant, and she had never had access to prenatal care. We were able to get her up to our OB program, get her in to see the dentist, not that day, but the next day. There were some things that were more important, and also get access to the medical and behavioral health care that she needed. That's whole person care. Because of Medicaid and the Healthy Babies Equity Act, we've helped 160 babies be born in Maryland through our new OB program just over the last 2 years. Because of Medicaid and the adult dental expansion, we can leverage private dollars to provide dentures for people, something that Medicaid doesn't cover. Because of Medicaid and the ACES waiver, Assistance in Community Integration Services, we're reducing hospital costs and helping 300 people find housing and keep it. Because of Medicaid, we help the most vulnerable get the care that, frankly, each of us deserves. So strong support of Medicaid. Please invest in helping people get enrolled and stay enrolled. And we're very thankful for the leadership of the MDH team.
Thank you so much. Do any subcommittee members have questions of this panel? I just have one. I spoke earlier with the department related to potential churn in Medicaid as a result of HR 1 and whether healthcare navigators might be supportive or helpful in that effort. Anyone want to comment on that? Do you think that healthcare navigators could help with ensuring those who
I think they absolutely could help in reducing. You know, we were talking earlier about healthcare navigators in SCHIP, so in exchange programs. We absolutely need additional navigators to, as was mentioned, and re-enrollment is now every 6 months and not every year. And so for vulnerable people, particularly for those that are residentially unstable, navigators to help find people and help them re-enroll. Enrollment can be a pretty arduous process, but specific navigators related to Medicaid, I think you'll hear from the broader advocacy community, are well needed to prepare for what's coming.
I would agree. I think we often hear that navigators are one of the weaknesses in our system in Maryland, and that there'd be a way, not just for this issue, but for many.
Thank you. Appreciate it.
I had a me too.
Okay. Lots of me too's. Awesome. Appreciate it.
I've not seen the advocacy community come together in such agreement.
Oh, I love that.
As I have with navigators.
Oh,
My
good.
goodness.
Okay.
It's
That's
quite
good.
remarkable. You
Everybody
have a win.
likes to help the helpers, right? Okay, good. Thank you so much, panel. Really appreciate your advocacy.
Thank you.
We'll now call our next 4 people to the table. Kyle Stone with Concerto Renal Services, Dan Martin, Mental Health Association of Maryland, Stephanie Clapper, Maryland Citizens Health Initiative, and Jesse Haviland. Do we see 4 people moving? 1, 2, 3, 4. Okay, great. You may begin while others are being seated. You can go ahead and start.
Terrific, thank you. Madam Chair, members of the committee, my name is Kyle Stone. I'm with a licensed home dialysis provider called Concerto Renal Services in the state of Maryland. I come to you, and I'm so grateful for the few moments I have to discuss our model of service. And it's not just the company I represent, it's others as well, who bring on-site dialysis to skilled nursing facility patients. These are the state's most highly acute patients who otherwise 3 times weekly would be shipped off to outpatient clinics, sometimes far away or during extreme weather, almost always in a Medicar, Medivan, or ambulance. For Medicaid patients, the transportation costs are a burden on the state Medicaid program. When dialysis is provided on-site to nursing home patients, the patients are safer, they're happier, and they're healthier. And that last adjective I used is not merely anecdotal, it's supported by data. Fewer mistreatments, fewer infections, fewer hospitalizations when they can receive the dialysis services on-site. All the while, Maryland coffers are lighter given the lack of transportation costs and the reduced cost of care. Now, currently, Maryland Medicaid treatments are inadequate to sustain these services, certainly to expand these services. Our service model treats a disproportionately high Medicaid population, particularly compared to conventional outpatient clinics. It's apples and oranges. We're treating a lot more Medicaid patients in a nursing home, have next to no commercial patients, I should add, compared to our brothers and sisters providing care on an outpatient basis. The result are access issues. SNF dialysis providers are incentivized to not service SNFs with a higher percentage of Medicaid patients. Where such services are provided, they're incentivized to pay close attention to the payer mix of the members they treat, which can get pretty uncomfortable. Our ethos as a provider is that we treat everyone. We celebrate that ethos. We live by that ethos. But it does have financial implications and does threaten the sustainability of this program. Now, currently there are about 200...
Sir, I'm so sorry, but your time has expired. Do you want to just finish your thought, please?
Sure. SNF dialysis has changed the way that SNF patients who require, with ESRD, require services, receive them. We appreciate the opportunity to partner with the department, partner with the committee to ensure the survival and success of these services.
Thank you so much. Next, please.
Thank you, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland, here in strong support of full funding for Maryland Medicaid. And I just want to start by thanking Medicaid and the Medicaid team for all of the work that they're doing to raise public awareness about the new requirements under HR 1 and everything they can do to make it as easy as possible for Marylanders to avail themselves of the health care coverage to which they're legally entitled. It is absolutely critical that they have the resources to keep people from falling off the rolls. And so I also want to thank Governor Moore for including funding in the budget to ensure that Medicaid can use existing data to verify eligibility and simplify the enrollment and re-enrollment process for Medicaid recipients. We'll get to, we've been talking about navigators, and so I want to be very specific because I put it in my written testimony, but I would also, we are also requesting additional funding for Maryland Medicaid for 100 local navigators at the local health department positions. We've asked for $8 million for Medicaid in our testimony, and it's because the Maryland Health Benefit Exchange's budget has money for the exchange navigators, and so does MDH at the state level, but there's no budget at the local level for local health department navigators who serve both as navigator and eligibility determination. So this is where many constituents will turn first. This is where much of the determination decisions are made. And if there's any questions about how we came up with that $8 million number, it's really tied to, we derived it from the Maryland Health Benefit Exchange navigator number, which is $10 million for kind of a similar amount of navigators. So with that, I also want to say just real quickly at the end, this is not just Mental Health Association of Maryland, the Maryland Behavioral Health Coalition, which we chair, which is over 60 nonprofit organizations from around the state working to improve access to mental health and substance use care, making sure that Medicaid has the funding that they need to properly ensure HR 1 and keep people from falling off the rolls is a priority for that coalition as well. And so with that, I'll just stop and thank you for the opportunity to testify.
Chair Shetty and members of the House Appropriations, Health and Social Services Subcommittee, my name is Jessie Haviland, and I thank you for this opportunity to testify on the importance of protecting Medicaid and the MDH budget. Medicaid saved my life, and I can say this with objective clarity. About a decade ago, I was a Medicaid recipient for almost 2 years while working as a part-time contractor. During that period, I went through the worst case of bronchitis of my life, and as an asthmatic, that was incredibly dangerous. I was bedridden for 3 weeks, only leaving the house to be driven to my doctor for daily nebulizer treatments. Medicaid was the reason I was able to receive life-saving care that I desperately needed, including multiple medications, inhalers, and treatments that would have quite literally bankrupted me had I had to pay out of pocket. The treatment I received under Medicaid prevented my bronchitis from turning into pneumonia, in turn keeping me out of the hospital. I urge you to fully fund Medicaid. Maryland must do everything possible to ensure that Medicaid continues to provide health coverage to its most financially and medically vulnerable residents like I was. Under H.R. 1, there will be new reporting requirements for adults who receive Medicaid through the ACA expansion. Reflecting back on my experience, I can't help but wonder if I would have lost my life-saving coverage when I needed it the most, due to missing those 3 weeks of work and being too sick to fill out and submit paperwork on my own. My experience shows that it could be easy for people to fall through the cracks and lose their health coverage under H.R. 1. Please invest in minimizing paperwork and making navigators available to help walk people through the process. Thank you very much.
Chair Shetty and members of the committee, I'm Stephanie Clapper, Deputy Director at Maryland Citizens Health Initiative. Our mission is achieving quality, affordable health care for all Marylanders. And with Maryland facing a significant budget deficit, I would like to thank Governor Moore for his commitment in his budget to funding Medicaid, and we urge your committee to do the same and protect Marylanders' access to health coverage. Under your committee's leadership, we have made great progress in Maryland, cutting our uninsured rate in half, and the adult Medicaid expansion has been a big part of that success. Keeping Marylanders insured helps all of us, because when people lose their coverage, they often are forced to get their health care in the hospital, in the emergency department, which is the most expensive place possible, and that resulting uncompensated care causes all of our health insurance premiums to go up. So this is not some of us problem, this is an all of us problem. As H.R. 1 is implemented, we applaud the Maryland Department of Health for their commitment to ensuring that the technology is updated to ensure that as few people fall through the cracks as possible by automating their redeterminations and their work requirement paperwork. We also urge you to fully invest in those technological needs, as well as 100 navigators at the local level, $8 million to fund that work so that they can help navigate people through the process and determine their eligibility. It's critical that Maryland continue to provide health coverage to its most financially and medically vulnerable residents, and we ask you to also consider the increased strain to our federally qualified health centers as more uncovered Marylanders turn to them for care. Together, we have made great strides in Maryland, and we thank you for your leadership and commitment to Marylanders' health and urge you to fully fund Medicaid and the eligibility operations and navigator support to keep people enrolled.
Thank you so much for your testimony. Thank you for sharing your story. Do any subcommittee members have questions of this panel? Okay, no, saying thank you. Thank you for being here today. Our final panel is Glenn Schneider from the Horizon Foundation, Lorraine Ericat from 1199 SCIU, and Lisa Carr from Service Coordination, Inc. And once you are seated, you can begin, so we can proceed. Thank you. Sir, go ahead.
Chair Shetty, members of the subcommittee, hi, my name is Glenn Schneider. I am the Chief Program Officer at the Horizon Foundation, our state's largest independent health philanthropy. And I am here to talk a little bit about Medicaid, to support fully the work that you've already heard about, talk a little bit more about the challenges that we see coming forward. Back in May, the Horizon Foundation saw what was happening with H.R. 1, and we started to convene all the Medicaid advocates around the state to see how we might be able to assist the state in keeping people enrolled and finding all the people who are eligible. We've been meeting together ever since. There are more than 70 groups and coalitions of groups that have come together. We've been sharing information. We've been coordinating with the state, with Perry's team, with the MCOs and others, and the exchange to make sure that we were all coordinated in one spot. I just wanted to talk about the challenges that we see here in front of us. How many of you have been to M&T Bank Stadium, or you've seen it on TV, right? That seats about 71,000 people. So imagine if we had 4.5 stadiums, sold out stadiums full of people coming to your office to find something that they value. Certainly the IT investments that we have are going to help, but there's going to be some people who don't quite understand how to access that. They're going to need extra help. And certainly we have navigators at the exchange who can help so much, but then the eligibility decisions, the kind of, if you put in some incorrect information on the form and you have to verify that, you're going to need extra help. We've been in touch with the health officers who are, by the way, in DC at a national meeting to ask them what they need, and they have all said the same, which is We can't do this type of work unless we have the extra staff to do it. We are not staffed to handle 4.5 sold-out stadiums full of people coming in needing help. So that is certainly our ask as well, $8 million for 100 navigators across the state. A big shout out to the governor, whoop whoop, for not cutting Medicaid in a major way. And certainly those IT investments are critical for all the reasons you heard already. Just one last point. Philanthropy has been doing its part as well. We've heard in all of our group convenings, time after time, the town hall meetings are showing that people believe that Medicaid does not exist. The secretary talked about this already. As people are getting denied SNAP coverage, perhaps, they realize, oh my gosh, I mustn't be eligible for anything. This needs to change. The Horizon Foundation and Krieger Fund have come together to fund a complementary communications campaign that we are coordinating with the state to make sure that people know that Medicaid still exists.
Thank you for doing that.
So thank you very much.
Thank
You bet.
you. That's wonderful. We really appreciate that support. Thank you, and thank you for your testimony and your enthusiasm for Medicaid. Yes, next, please.
Good morning, Chair Shetty and members of the committee. My name is Lorraine Aricott. I'm the Senior Policy Analyst with 1199 SCIU. We're the largest healthcare workers union in the nation, representing over 10,000 healthcare workers in Maryland and DC across the care continuum, that is through hospitals, nursing homes, and federally qualified health centers. 1199 greatly supports all of the work the state has done to protect Medicaid. We have been in coalition with Caring Across Maryland, with 12 other organizations that are representing consumer and worker organizations to protect long-term care. Our members know that Medicaid is essential and integral to some of Maryland's most financially vulnerable individuals, our seniors, those who need care at home and also in facilities. 5 and 8 nursing home residents rely on Medicaid, and for those reasons and so much more, we support all of the work that the state is doing. 1199 is also very proud to stand in solidarity with the broad base of coalition of supporters who are protecting and defending Medicaid and calling for additional funding for healthcare navigators. Our healthcare workers know that when Marylanders lose coverage, they're going to emergency departments. And Maryland has one of the longest ER department wait times in the nation, and our healthcare workers are overburdened, they're understaffed, and really need the state to invest in healthier communities and really protecting healthcare coverage. And we know that when healthcare navigators are funded at the local level, we can really try to push back against some of the unintended or intended consequences of HR 1, which is really pushing people into these administrative burdens of these work requirements. Most states that have work requirements, we know that it doesn't actually increase employment. In Maryland, the vast majority who are already working or have a reason to not be, like going to school or serving as a caregiver or have a disability, the administrative burden is just simply another barrier for them to maintain Medicaid coverage. So for those reasons, we also do a Me Too for the $8 million for 100 healthcare navigators, especially in a time like this. And with that, I thank you for the time to testify.
Hi, good afternoon, Chair Shetty, members of the committee and guests. My name is Lisa Carr. I'm the Director of Government Relations for Service Coordination, Inc., or SCI. SCI is a nonprofit organization providing conflict-free targeted case management services to 16,000 people of all ages and disabilities and complex medical needs across Maryland. We support 4,500 people through SCI's support planning case management services. SCI supports planners provide targeted case management in 4 programs: the Community Personal Assistance Services, or CPAS program, the Community First Choice, or CFC program, the Community Options, or CO waiver, and the Increased Community Services, or ICS program. Supports planners are case managers who manage program and waiver applications. They assist with maintaining enrollment. They monitor health and safety needs, as well as coordination and oversight of service providers. We have 3 recommendations for your consideration. The first is to ensure competitive reimbursement rates and provide cost of living increases for home and community-based service providers. The second is to address the unmet needs by reducing the community options waiver registry and improving efficiency and management of that registry. We know there are over 20,000 people on the community options waiver registry waiting to apply for services. And we're encouraged to hear about the report that we just heard earlier today and the analysis and the testimony on the CFC and CO waivers. The report that's referenced in the DLS and MDH testimony and report will look at the waiver slots and the community options registry, and we're really happy about that. The third recommendation is to provide support and resources to the Maryland Department of Health Eligibility Determination Division to help them manage eligibility and redetermination processes and to respond to inquiries in a timely manner. We did submit written testimony, which includes a story of a person who has received services from us, from Support Planning Services. Some of the people who provide support planning services are here with me at the hearing. And thank you for the opportunity to speak with you today.
Wow, you must have practiced. You finished right on time. Well done. Do any subcommittee members have questions for this panel? Okay, seeing none. Thank you so much for your advocacy and enthusiasm for Medicaid. That concludes our budget hearing on the Medicaid program. Colleagues, we will see you tomorrow for Developmental Disabilities Day. Thank you.